and gone are the days of those most common and least common. Now, you are also being checked on the clinical part of the subject. And understanding the clinical part of the subject is a different ballgame altogether. You have to change the way you are studying. Surgery being a clinical subject, just knowing those theoretical points that this is an investigation of choice for this is the most sensitive investigation for this is the most specific investigation for this is not going to help you at all. You have to know that how are you go about a particular patient in the ward in the hospital. So for understanding that, you have to have the knack of a clinical approach. And in this surgery discussion, we will be talking about the clinical approach to the subject. Right? There is a gross change. Many of you are seeing the familiar basis there. Many of you have already appeared in this exam, and you all know that it is not the same exam was used to be done. So our approach has to change. Our way of teaching also should change now. We should evolve. And let me tell you a very important point here. So very important point here is that in 2023, there is going to be next. And this next, if we don't clear this exam this time or in coming times, then it is going to be very tough because then you will be competing with the Indian medical graduates. And that exam is going to be not only your licensing exam, that exam is going to be your exam for selection in the fourth year. So you have to clear this exam this time only, and you have to change the way you are studying. You can't overnight change the way you are studying, but the only thing you can do there, and the thing which you can help you there, is doing more of clinical questions. Try to attend more of clinical questions. Because you will not be fair. Those who have appeared the previous exam, let me tell you, I'm not actually scaring you, but then this is a fact. If you ask me, last year, the kind of exam we had, the FMG exam, it was much tougher than actually today. And when I saw that paper, I felt so bad for you guys because at your level, you are actually not exposed to those kind of questions. You don't know that what future are you going to use in a given situation. You have not used it. You will be using it once you start your internship. So asking you all those things in your exam is actually not the right thing, but they're doing it. So point to understand here is that National Board of Examination is conducting this exam. And National Board of Examination is also conducting a NEET exam. They have a set of question banks which they prepare, and they randomly select these questions to be put in a FMG or in a NEET exam. So that means whatever questions are there for me can be questioned for you also. So we have to prepare according to the NEET pattern, right? And that is the reason why all these apps which are there available in the market, they also say that these apps are good enough for you also, right? But then at your level, you have a limited time to finish off your 19 subjects. It is not that you have 1 year to finish off those 19 subjects which otherwise a NEET aspirant has. You have a limited time, and in that limited time, if you see a particular video for those many hours, it is not humanly possible to finish all those 90 subjects in a given time. So what we are going to do here, that we will devise a strategy. We will try to understand the subject in a very concise, but at the same time in a very conceptual manner. I am one of those who believe, who is a strong believer of concept-based teaching. I am one of those many students I can see who have attended my classes. They know how I conduct my classes. You can talk to them, they can tell you that you should not hesitate at all in asking a question. You are there to clear your doubts. If you are just writing these notes, my notes are available now. There is no point just writing these notes because it is all about understanding. So if you are not understanding it there is no point sitting in the class first. You should better invest time in your self-study and just mother those notes which are available in the market. But then just mugging up things is not going to help at all now. You have to have a clinical understanding of the subject, which with this discussion on surgery, I will try to impart. And you can be rest assured here on the subject, particularly in surgery. I don't indulge in other subjects. This is my forte, so I'll talk about surgery only here. But I assure you on this, that whatever we discuss here is going to be very high yield, and the questions will come from what we are going to discuss. Right? And you can also make out the way I'm going to discuss things. Whatever topic I'm going to discuss in detail, you can make out that topic is an important topic. That is why I'm giving more stress to that topic. There are few topics which are so important in our exam, in surgery, that you can't just appear in your exam without knowing those topics. Like if I have to tell you that randomly at this moment which topic is the most important topic, you all also know, and that is in surgery strong. If there are 20-25 questions on surgery, there will be 7 or 8 questions on trauma. So that way trauma is very important. Similarly, breast is another important topic. We will get 2 or 3 questions. And then now, general surgery is a very, very important topic. So whatever topic which are important, we will be giving more stress on, and I will try to make you understand the clinical approach rather than just giving you the raw things of actual information to mother, right? But then please don't at all hesitate in asking questions. It is your duty. Don't let me do this work without clearing your doubts, because you are there to clear your doubts. So please make sure that your doubts gets clear. Even if that's a very silly question, don't hesitate asking, because if that doubt persists in your mind, then if the question comes on the similar thing, then you will not be able to answer. And if you are not able to answer, it is going to be a problem, right? And there is a good side of this also. There is a downside of it, that the paper is very difficult now. The paper is different now, but then there is a good side also. The good side of this is that it's a NEET exam. It is now a NEET exam for you actually. It is just that you have to finish those 90 subjects in less time. But the good side about it is this, that you can take it as a rehearsal for your NEET exam. Because let me tell you very frankly, I'll be very blunt on your face. Because I should show you the right thing. Just being MBBS is love. इससे तो हम MBBS ना करते तो ज्यादा करते, क्योंकि तब हमें इस बात का अफसोस तो नहीं होता कि हम डॉक्टर होके भी इस स्टेज पे, राइट? अपने आप में जो कॉम्प्लेक्स आएगा सिर्फ अगर आप MBBS रह जाते हो। और आजकल जमाना कैंसर आजकल MBBS तो सोच भी नहीं सकते। We are now in an era of super specialization, not only super specialization, we are in an era of organ specific approach. तो आप सिर्फ MBBS रह गए तो it is not going to work, and you can take it as as a good thing actually, because anyways आपको नीट एग्जाम देना है और ये एग्जाम क्लियर के बिना आगे लाइफ बढ़नी नहीं है। तो इस एग्जाम में इस तरह से पढ़ाई की जाए कि आपका नीट एग्जाम के लिए रिहर्सल हो जाए, तो आपका नीट एग्जाम आपके लिए आसान हो जाएगा। हालांकि देखो ये बहुत ह्यूमनली वो है कि आप सोचते हो जो एग्जाम है उसको करते हैं पहले, आगे का क्या सोचना, बट जो आगे की सोचता है ना वो आज की डेट में आगे बढ़ता है। What I believe now, I'm senior to you, so I can say this now. Achievement delayed is achievement denied out now. अगर आप कोई चीज अचीव कर रहे हो और उसको लेट अचीव कर रहे हो तो उसका आप मजा नहीं ले पाओगे। अगर आपको अचीवमेंट अचीव करनी है तो उसको राइट टाइम पे अचीव करोगे तभी उसको एंजॉय कर पाओगे। लेट अचीव करके कोई उसका मजा नहीं ले पाओगे। ये बातें सुनने में अभी लग रहा है कि प्रीचिंग है, बट ये एक्चुअल में जब तुम मेरी स्टेज पे आओगे, जो तुम लोग अब कर रहे हो वो मैं कर चुका हूँ, जो मैं कर रहा हूँ वो तुम करोगे, राइट? तो हम सबकी लाइफ, हम सारे मेडिकल्स की लाइफ एक ही तरह से चलती है। तो जो मैंने किया है और जो मेरा एक्सपीरियंस है, मेरी रिस्पॉन्सिबिलिटी बनती है कि तुम्हें बताऊं कि यू शुड प्रिपेयर योरसेल्फ अकॉर्डिंगली, कि ये सिर्फ अपने आप को ना ये चैलेंज दो कि मैं सिर्फ एग्जाम क्लियर करने के लिए नहीं पढ़ रहा हूँ, मुझे नीट क्लियर करना है। ये तो एक एग्जाम है जो मुझे करना ही पड़ेगा, मजबूरी है, बट मेरा मेन एम नीट है। एंड आई कैन टेल you are all good students. We have one student, there are few students who keep messaging me, and one of them, let me tell you, I don't know how many of you know him or not. This Shubham is a guy, I don't know, he's a senior to you though. He got into cleared his exam in a second attempt, this FMG exam, and he got 155 or 156 in FMG exam. In NEET, he got a rank of 540, and he will be getting a radiology, and he's coming to discuss with me that whether he should take a radiology or he should take a medicine. So imagine, it is all achievable, it is all doable, it is all here. Impossible also says I am possible. So आपको मेक बिलीव करना है, आपको अपने आप को चैलेंज देना है कि मुझे करके दिखाना है। तुम्हारे पेरेंट्स ने बहुत मेहनत करके तुम्हें एक जगह पे एक मकाम दे दिया है, तुम्हारे पास एक बेस आ चुका है, उस बेस को वेस्ट मत होने दो, उस बेस को यूज करो और आगे बढ़ो, मेक देम प्राउड, राइट? सो इफ यू वर्क हार्ड, नथिंग इज इम्पॉसिबल। इट इज जस्ट अबाउट अ माइंडसेट। अपने आप को ये एक अपने आप से दिमाग से टेक दिस कॉम्प्लेक्स आउट ऑफ योर माइंड, that since I see that, I always tell all my FMG students that take this mindset out, that since you are from foreign medical colleges, your level of preparation is not equal to what Indian medical graduates have. ऐसा कुछ नहीं है। Indian medical graduates हवाबाजी ज्यादा करते हैं, बट ऐसा है नहीं। अगर आप अच्छे से पढ़ोगे और अब टाइम है, जो टाइम चला गया, इस टाइम को अगर हमने अच्छे से यूज कर लिया तो हम लाइफ को बहुत बेटर लीड कर पाएंगे और अपने आप पे कॉन्फिडेंस भी फील करेंगे, ठीक है? सो विद दिस नोट एंड विद दिस assurance from you that if at all you have any doubt, you will be stopping me there and asking me question. I'm going to start, right? And the way I'm going to teach now is going to be majorly different, because I also have to evolve as a teacher, because the kind of questions which are coming are not straightforward questions. So I have to prepare you for those kind of clinical questions in that way only, because if I don't prepare you that way, then those factual informations you probably will not be able to apply when it comes to the exam. So I'll try to give you the insight of a clinical thing here, so that whatever the question is framed to you, you have to know, right? So we will भाग रहे हो आपको, और if I'm going slow, at the same time tell me sir क्या है, sir नींद आ रही है,
थोड़ा सा तो आगे चलो. So please, you can. So what I am trying to convey through this is that you can talk to me in any which way. Okay. So feel free and interact with me in any which way. Okay. So we are going to start the discussion. We'll be starting breast. देखो सबसे पहले ना एक मेरी बहुत सिंसियर रिक्वेस्ट है तुम लोग को, इससे इससे नहीं ये फैन जब आता है ना तभी देखो अभी नहीं होगा, अभी नहीं होगा. इसको मेरी तरफ से हटा दो, कोई बात तुम अपने ऊपर रख लो. यहाँ पे आया ना, इसको यहाँ से हटा दो. तो तू तो जाके बैठ. करें शुरू. तो we are going to start here and just let me know what all subjects यहाँ पे हो गए. सब हो गए, almost सब हो गए. Very good. So you have the already some understanding of the anatomy, so it will be easier for me to go about now. Okay. So but then we will have some important information on anatomy also. So we'll start with the surgical anatomy. First of all, there comes the extent of the breast. In surgical anatomy, what is the extent of the breast? Breast extends from second to sixth rib in mid-clavicular line and from a lateral border of sternum to anterior or mid axillary line. Is it legible at the back? ठीक है, font size ठीक है, कि बड़ा करूं, ठीक है, ठीक है ना, ठीक है ना. So थोड़ी सी राइटिंग में जूझोगे समझने में, बट आई कांट हेल्प इट यार. राइटिंग में चेंज नहीं कर सकता, यही है. किसी को कैलीग्राफी किसी को कैलीग्राफी मानो और दिल में सोचो कि यही अच्छी है, और कोई बहुत खराब सी हैंडराइटिंग देखो और फिर इसको देखो तो अच्छी लगेगी, ठीक है ना. तो सेकंड to sixth rib in mid-clavicular line and from a lateral border of sternum to anterior or mid-axillary line. दूर से क्यों? anterior or mid-axillary line, right? Now, why we need to know the extent of the breast? It has a reason. You all know that there is something called suffix called ectomy. What is ectomy? Removal of something. So when I say mastectomy, what does that mean? Removal of the breast. So whenever I am removing a breast, I need to understand, since breast extends from second to sixth rib in the midclavicular line and from lateral border of sternum to anterior or mid-axillary line. So if this is the sternum and this is if the breast, it is second rib, it is sixth rib, right? So lateral border of sternum, second rib and sixth rib. So whenever I am going to remove breast, I have to remove all this part of the breast. So whenever we remove breast from second to sixth rib in a midclavicular line and from lateral border of sternum to anterior or mid-axial line, this surgery, I will call it total mastectomy. And sometimes people use simple mastectomy also as a term for this. So what is total mastectomy? That means removal of whole breast. And what do you mean by whole breast? Second to sixth rib in midclavicular line and from lateral border of sternum to anterior or mid-axial line, right? So this is something called total mastectomy, right? Now let us understand the other types of mastectomy. I'm going to change the way I used to teach, because the kind of questions we're getting is grossly different now. So this is total mastectomy. This is, or sometimes called simple mastectomy, right? Then there is a term called radical mastectomy also. Then there is a term called radical mastectomy. So what do you understand by a term when it comes as a radical mastectomy? Removal of nearby parts, okay? See, let's understand these terms because ultimately we will be applying these terms in our given clinical scenario, right? Radical mastectomy term, as the name suggests, radical. Radical means extra. When you are going to remove not only breast, along with breast, the other things also, it means we have to use radical as a term. And in that radical term, earlier we were doing a type of mastectomy in radical mastectomy called Halstead's mastectomy. Halstead's radical mastectomy. Halstead radical mastectomy. Now, what is this Halstead radical mastectomy? Halstead radical mastectomy is removal of the breast with nipple areola complex, removal of breast with nipple areola complex. Along with that, if I remove pectoralis major and pectoralis minor muscle also, if I use pectoralis major and pectoralis minor muscle also with lymph node removal along with this, whenever I am going to do this whole removal, this procedure will be called a radical mastectomy or Halstead's mastectomy. This procedure is going to be called a radical mastectomy or a Halstead's mastectomy, right? Now, then there is another type of mastectomy also. Lymph node removal. Pectoralis major, pectoralis minor, and lymph node removal. Okay. When we are going to remove all these things, it will be called a Halstead mastectomy or radical mastectomy. Then there is a term called Petty's mastectomy. There is a term called Petty's mastectomy, which is also called Petty's modified radical mastectomy. This Petty's mastectomy is also called Petty's modified radical mastectomy. So please be careful about it. If you are told that what you do in Halstead mastectomy is radical mastectomy. Okay. Petty's mastectomy is Petty's modified radical mastectomy. So what is modified radical mastectomy here? In radical mastectomy, we were removing all these things, right? This lymph node removal we'll be talking about in detail later. I'm just going to give you the importance of this anatomy surgically now, right? So, Petty's modified radical mastectomy is whenever you remove breast with nipple areola complex, with pectoralis minor muscle and lymph node removal. This procedure will be called as Petty's MRM or Petty's mastectomy. So what does it means? That in Petty's MRM, very important glaring difference, that the only thing changed here is pectoralis major muscle, major muscle was spared. So this is a very commonly asked question, that which muscle, which of the following structure in Petty's mastectomy is spared, right? So what muscle, what structure is spared? It is pectoralis major muscle, right? So this is what is called Petty's mastectomy. There was Wellstead mastectomy, and then there is a total mastectomy also. So we have understood the various types of mastectomy. We'll talk about, there are another surgical procedures also. We'll talk about them later, right? So this is what is the anatomy, and this is what we are doing as a surgery. Now coming on to another very important point about anatomy of the breast and its importance clinically. You all know the blood supply of the breast. Can you tell me what is the blood supply of the breast? You already have done. The breast receives its blood supply from branches of internal mammary artery. Breast receives its blood supply from branches of internal mammary artery. It also receives its blood supply from branches of axillary artery. It also receives its blood supply from branches of axillary artery, and it is also receiving a blood supply from the branches of posterior intercostal artery. So breast is receiving its blood supply from branches of the internal mammary artery, branches of the axillary artery, and branches of the posterior intercostal artery. Right now, okay. Now, first of all, you all know that all the veins in the body, you already know this, that all the veins in the body runs parallel to the arteries, right? So all the veins in the body runs parallel to the artery, we know that. So that means there will be a corresponding veins here. There will be a corresponding veins here. There will be internal mammary vein, there will be axillary vein, and there will be a posterior intercostal vein also. Agreed? Yes. All of you? Right? Now, as a concept, remember, this will help us in answering many questions. You all know that all the veins in the body runs parallel to the arteries. Now, from now on, you should know that all the lymph nodes in the body, as a rule, remember, all the lymph nodes in the body are sitting on a vessel. These are those vessels which are supplying that organ. All the lymph nodes in the body are sitting on a vessel. These are those vessels which are supplying that organ. So that means if you know the blood supply of any organ, if you know the blood supply of any organ, you can easily make out the lymphatic drainage of that organ. Now, with this understanding, we can easily say that since the blood supply of the breast is coming from internal mammary artery, axillary artery, and posterior intercostal artery, so there will be a lymph node sitting on the axillary artery and its branches. There will be lymph nodes sitting on posterior intercostal artery and its branches. There will be lymph nodes sitting on internal mammary artery and its branches also, right? So there are going to be axillary group of lymph nodes. There are going to be axillary group of lymph nodes. There are going to be internal mammary group of lymph nodes. There are going to be a posterior intercostal group of lymph nodes. So there are going to be axillary group of lymph nodes. There are going to be an internal mammary group of lymph nodes, and there are going to be a posterior intercostal group of lymph nodes. Right? Now, out of these various groups of lymph nodes, a very commonly asked question. This is a very, wherever I am telling you, it is commonly asked, it is checked, please highlight that in your notes. Okay. So it is a very commonly asked question that majority of the lymphatic drainage of the breast goes to. Can you tell me the majority of the lymphatic drainage of the breast goes to? Axillary group of lymph nodes. The majority of the lymphatic drainage of the breast goes to axillary group of lymph nodes. Now, why is it this? That majority of the lymphatic drainage of the breast is going to axillary group of lymph nodes, a very commonly asked thing in exam again. You all know that, and if we understand the concept in that, we don't have to mug up things. What is that concept? See, this is breast. Imagine this is a breast. And you all know that breast is divided into four quadrants. Upper inner, upper outer, upper inner, upper outer, lower inner, lower outer. Right? Now, upper inner, upper outer, lower inner, lower outer. And very, very important point to note, majority of the breast tissue, is present in the outer upper quadrant. Majority of the breast tissue is present in the outer upper quadrant, and this part of the breast is supplied by axillary artery and its branches. Now, since majority of the breast tissue is present in the outer upper quadrant, that is the reason why the majority of the lymphatic drainage of the breast goes to axillary group of lymph nodes, because this part of the breast is mainly supplied by axillary artery and its branches. So majority of the breast tissue, since present in the outer upper quadrant, that is the reason why the majority of the lymphatic drainage goes to axillary lymph node, because this part of the breast is supplied by axillary artery mainly, right? And the importance of knowing this fact will help you in answering many questions now. Since majority of the breast tissue is present in the outer upper quadrant, you can take it as a blanket statement. You can take it as a blanket statement that any pathology in the breast, be it fibroadenoma, be it carcinoma, be it Phyllid's tumor, be it fibroadenosis, whatever pathology asked in your exam, you don't have to mug up. You just have to remember the most common site of any pathology in breast for this very reason is outer upper quadrant. So most common location of any pathology if asked, it will be upper outer quadrant, right? And this upper outer quadrant is supplied by axillary artery, and that is the reason why majority of the lymphatic drainage is going to axillary group of lymph nodes. Now this axillary group of lymph nodes are further divided into, very important, these axillary group of lymph nodes are further divided into anterior group. The axillary group of lymph nodes are further divided into anterior group, posterior group, lateral group, rotors group, central group, and apical group. The axillary group of lymph nodes are further divided into anterior group, posterior group, lateral group, rotors group, and please highlight it in the notes. This rotor group is also called interpectoral group. This rotors group is also called interpectoral group. There is central group and there is a apical group. Okay. Now, so these are the axillary group of lymph nodes, right? Now, please understand this. This is a very important clinical concept, and this they can ask you again in a clinical way. Okay. Now, first of all, you know that the majority of the lymphatic drainage is going to the axillary group of lymph nodes, right? In axilla, these are the lymph nodes. Now, let's understand this. देखो क्या है? Lymph nodes are receiving lymph. And this lymph is then eventually is going to the heart. This lymph is eventually going to go back to the heart. So how the lymph is flowing? देखो, please try to understand this. एक तो होता है कि आपने ये देख लिया कि इस ऑर्गन की यहाँ पे लिम्फ नोड है, यहाँ पे लिम्फ नोड है, यहाँ पे लिम्फ नोड है, एक्सिलरी आर्टरी के ऊपर अराउंड लिम्फ नोड है, इंटरनल मेमोरी आर्टरी के अराउंड लिम्फ नोड्स है, पोस्टीरियर इंटरकोस्टल आर्टरी के अराउंड लिम्फ नोड्स है. ये तो आपको पता लगा इस ऑर्गन की ये लिम्फ नोड्स है. अब इन लिम्फ नोड्स में लिम्फ कैसे फ्लो हो रहा है? हाउ द लिम्फ इज फ्लोइंग इन दीज लिम्फ नोड्स. ये जो हमने पता लगाया तो ये एक्सिलरी लिम्फ नोड है, ये इंटरनल मेमोरी लिम्फ नोड्स है, ये पोस्टीरियर इंटरकोस्टल लिम्फ नोड्स है. ये हमें पता लगा एनाटॉमिकल डिस्ट्रीब्यूशन. ये तो एनाटॉमी है लिम्फ नोड्स की, यहाँ लिम्फ नोड पड़ी हुई है. अब इन लिम्फ नोड्स में लिम्फ फ्लो करता है, लिम्फ नोड से लिम्फ फ्लो करता है. लिम्फ नोड में लिम्फ कैसे फ्लो करता है, लिम्फ कैसे पर्टिकुलर लिम्फ नोड में फ्लो कर रहा है, वो होता है सर्जिकल डिस्ट्रीब्यूशन. एक होता है एनाटॉमिकल डिस्ट्रीब्यूशन ऑफ द लिम्फ नोड. There is something called surgical distribution of the lymph nodes. What is this surgical distribution? Surgical distribution का मतलब होता है कि कैसे lymph particular lymph nodes में flow कर रहा है, right? ये पता लगाया सर्जन्स ने कि कैसे lymph breast का ये जो अब हमें पता है कि मेरे पास 3 जगह जाने की. मैं एम्स भी जा सकता हूँ, मैं मैमसी भी जा सकता हूँ, मैं जीटीबी भी जा सकता हूँ. मेरे पास 3 जगह है. मैं कहाँ पहले जाऊंगा वो मेरे ऊपर डिसाइड करेगा कि मैं कहाँ पहले जाना चाहता हूँ. तो इसी तरह से लिम्फ इन 3 ग्रुप ऑफ लिम्फ नोड्स में से कैसे जा रहा है वो स्टडी किया सर्जन्स ने, और इसकी जरूरत क्यों पड़ी अभी हमें समझ आएगा, राइट? तो कैसे ये लिम्फ जा रहा है, दिस वाज स्टडीड बाय सर्जन्स. एंड व्हाट दे हैव फाउंड आउट कि ब्रेस्ट से जब लिम्फ निकलता है, सबसे पहले जब ब्रेस्ट से लिम्फ जाता है वो सबसे पहले जाता है एक सर्टेन ग्रुप ऑफ लिम्फ नोड्स को. 3 पर्टिकुलर लिम्फ नोड्स हैं जिनमें सबसे पहले लिम्फ जाता है. दिस वाज द ऑब्जर्वेशन मेड बाय सर्जन्स एंड दैट दे कॉल्ड इट एज लेवल 1. कि सबसे पहले लिम्फ जा रहा है इन लिम्फ नोड्स पे, जो कि सर्जन ने पता लगाया. फिर उसके बाद लिम्फ जा रहा है, then the lymph is going to another certain group of lymph nodes, level 2, and then they found that the lymph is going to another certain group of lymph node called level 3. अब ultimately हमें पता है कि lymph जाना है lymph node से, और lymph node anatomically कहीं कहीं located है. तो अब ये lymph कौन सी लिम्फ नोड में सबसे पहले जा रहा है, वो कौन सी लिम्फ नोड है जो सबसे पहले लिम्फ रिसीव कर रहे हैं, जिनको हमने लेवल 1 बोला. इट इज इंपॉर्टेंट फॉर अस. दीज आर एंटीरियर, posterior and lateral group. These are anterior, posterior and lateral group. Level 2 lymph nodes are central and rotus group. Level 3 is apical group. So lymph कैसे फ्लो कर रहा है ब्रेस्ट का, सबसे पहले जा रहा है एंटीरियर, पोस्टीरियर और लैटरल ग्रुप ऑफ लिम्फ नोड्स में, फिर उसके बाद जा रहा है सेंट्रल एंड रोटस ग्रुप में, और उसके बाद जा रहा है अपाइकल में. अपाइकल के बाद कहां जा रहा है, अपाइकल के बाद जा रहा है सुप्रा क्लैविकुलर लिम्फ नोड. उसके बाद लिम्फ जा रहा है सुप्रा क्लैविकुलर लिम्फ नोड, और सुप्रा क्लैविकुलर लिम्फ नोड के बाद जा रहा है इंटरनल जुगुलर वेन. दिस इज हाउ द लिम्फ ऑफ द ब्रेस्ट इज फ्लोइंग. दिस इज हाउ द लिम्फ ऑफ द ब्रेस्ट इज फ्लोइंग. अब ये तो हुई हमारी थ्योरेटिकल अंडरस्टैंडिंग. इसका क्लिनिकल एप्लीकेशन क्या है, बहुत इंपॉर्टेंट डिस्कशन है. और आई एम many of you already have my notes. I can see, but then the way I am going to present them is going to be grossly different, because you have to get the understanding of the application of this what we know already. तो level 1 lymph node है, level 2 lymph node है and level 3 lymph node है, और level 3 के बाद lymph node से lymph जा रहा है supraclavicular lymph node. अब इसका क्लिनिकल, ये तो थ्योरेटिकल बात हमें पता लग गई. अब इसका क्लिनिकल एप्लीकेशन क्या है. एग्जामिनर आपसे क्वेश्चन कैसे पूछेगा और उस क्वेश्चन को आपको इंटरप्रेट कैसे करना है, वो ये अंडरस्टैंडिंग अब हमें आनी होगी. पहली बात तो कि हमें ये जानने से एडवांटेज क्या मिला और इसका हमें क्लिनिकली कैसे अप्लाई करेंगे. मोस्ट कॉमन malignancy worldwide. Most common malignancy worldwide now is breast malignancy. Carcinoma breast is a most common malignancy now. Carcinoma breast is a most common malignancy now, and the most common mode of spread of carcinoma breast is lymphatic. Most common mode of spread of carcinoma breast is lymphatic, right? अब क्योंकि carcinoma breast is the most common malignancy worldwide and most common mode of spread of carcinoma breast is lymphatic, so that is why lymphatic flow of the breast was extensively studied. तभी हमें ये सब पता लगा. अब इस सब का पता लगने से हमें एडवांटेज क्या मिला. पहली बात तो whenever a patient of a breast pathology comes to us, please understand this. Whenever a patient of breast pathology comes to us, we have to examine the patient, right? Now, how are we going to do a clinical examination? Now, can one of you come? Please come. Take a chair. Now, whenever a patient comes to us, this all is important for you now. Okay, whenever a patient comes to us, we are supposed to examine the patient, right? And in examination of the patient, we have two ways of examination, right? First of all, you should know the best way to calculate best. Please use maximum English. Okay. I thought you are not. Yes, sir. You are not. Examination of the patient, we should always use flat of our fingers, never the tip of our fingers. Okay. This was also one of the questions. That in examination, what part of the hand should be used? We should use flat of our fingers. Now, I have two ways of examining mainly. I can see like this. So one of the
of examination is, one of the way of examination is, I go like this. I go like this. If I consider this as a clock. I consider this as a clock. I consider this as a clock, and I examine the breast like this. In a clockwise manner, in a clockwise manner. When I dial of a clock, I have considered breast as a dial of a clock, and I have examined the breast in a clockwise manner. One of the way of examination is this. So this is called dial of a clock method. What is this method called? Dial of a clock method. Another method is I'll start from here and go like this, go like this, go like this, like this. I go like this, 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 like this. So in vertical lines, I'm going like this. So there are two methods. One is a dial of clock method. Another is a vertical line method. So there is a vertical line method and there is a dial of clock method. Out of these two methods, commonly done method is a dial of clock method. And why you need to know this? Because you may be asked in your exam now, you may be shown a video that the examiner is doing the examination. Tell me what method of examination is following. So we should know that what method of examination is being followed in breast. So there are two methods, dial of clock method and vertical line method. And commonly followed method is dial of clock. Then comes another thing. Now we know that most common malignancy worldwide is breast. Breast malignancy is the most common malignancy worldwide, right? And the most common mode of death of breast malignancy is the So that means whenever a patient of breast comes to me, I will have to not only examine axilla, I have to also examine the supraclavicular region. Because the flow of the lymph we have just studied. What we have studied, we are applying it now clinically, right? Now, how to examine the axilla? How to examine axilla and what lymph nodes are going to be palpated out. This is something important, and examiner how the question will be framed to you. You will understand. Now, imagine he has a problem. He has a problem in his left breast. Imagine, right? This is the left. So imagine he has a problem in the left breast. So for left breast or left axilla, for certain group of lymph nodes, I am going to use my opposite hand. So my opposite hand is a right hand here. So I use this resting hand here. So I put my hand, the left hand of mine on his shoulder. That's right. So I will examine this part of this fold, anterior axillary fold. When I am examining this anterior axillary fold, I am examining anterior group of lymph nodes. So in this anterior axillary fold of mine, this anterior axillary fold, there is an anterior group of lymph nodes, right? Then what I do, I lift this hand and palpate on the chest wall like this. Palpate on the chest wall like this, right? Against the chest wall like this. What I am palpating? I am palpating central group of lymph nodes. So I am palpating central group of lymph nodes like this. Now what I do? I extend his hand and I insert my finger deep inside. I poke my finger deep inside, and then again I lower, and again I examine like this. So what lymph node I am examining? I am examining a hyper lymph node, right? So that means for left axilla, I have used for right hand for palpating anterior, central. Now I have to examine the lateral and the posterior lobe. So for lateral lobe, I will use my same hand as the problem axilla is, right? So if it has a left axilla problem, left breast problem. So I use my left hand and I can calculate the lateral group of lymph node like this. I will calculate the lateral group of lymph node with my left hand, right? And then I'll go behind. Then I go behind, and in that behind, I will hold the patient's hand like this, and now I will examine the posterior axillary fold from behind, and with the left hand, I am examining the posterior axillary fold and the posterior lymph, right? And then I examine the supraclavicular lymph node like this. Now, why? Thank you. Why it was important for me, important for you to know all this, how the question will come to you. The question will come like this, that the examiner is doing the examination of the axilla, and in that examination of the axilla, the examiner has hyperextended the hand and then palpated a certain group of lymph node. They can ask you what certain group of lymph node the examiner has examined, one. Second, they can ask you this lymph node which the examiner has examined is going to drain to which group of lymph node. So now we know that after hyperextension of the hyperabduction of the hand, poking the finger deep inside, I will palpate and this apical group of lymph node is going to drain into supraclavicular lymph node. Now another important point about this clinical examination part. We are trying to understand the application of what we have learned here, right? Now, in this examination part, anterior, posterior, lateral group of lymph nodes are palpated, central group of lymph nodes are palpated, and rotus group are sometimes difficult to palpate at your level, not required, and then there's a apical group, right? The important point for us to know is what advantage we get with this. Imagine one patient has come to you with a carcinoma of breast. One patient has come to you with a carcinoma breast. There is a lump in the breast, and that lump turned out to be a carcinoma breast lump. In that particular patient, imagine there is no lymph node in the axilla. Just imagine I examined all the groups, there were no lymph node enlarged in the axilla. Another patient has come with a carcinoma breast lump, and in that particular patient, level 1 lymph nodes are found to be enlarged. A third patient has come who has a lump breast, and that lump is a carcinoma breast lump, and in that patient, apical lymph node is also enlarged. Now, in these three patients, just on clinical examination now itself, you can easily say that the first patient has a better survival chances, the second patient will have a better survival chances, and the third patient will have a worse survival chances. So just by a clinical examination itself, by knowing this surgical distribution, we can easily say that the prognosis of the patient, which patient is going to be good, which patient is going to be bad. So this surgical distribution of the lymph nodes is for prognosis. So there was a question asked, what is the advantage? What is the advantage of a surgical distribution of the lymph node? It helps in prognosis. The surgical distribution of the lymph nodes helps in prognosis. Right now, another important point. I have told you anterior, posterior, lateral, level 1, central and rotor, level 2, apical are level 3. Right? Coincidentally, this was a question asked. Coincidentally, these lymph nodes were found to arranged in relation to a pectoralis minor muscle. Coincidentally, these lymph nodes were found to be arranged in relation to one particular muscle, and that one particular muscle is pectoralis minor muscle. So this pectoralis minor muscle is important for you. The level 1 lymph nodes are below and lateral to pect minor. Level 2 are behind pect minor. Level 3 are above and medial to pect minor. Level 1 are below and lateral to pect minor.
level 2 are behind pect minor, level 3 are above and medial to pect minor. And you already know now that this is how the lymph of the breast is flowing. This is how the lymph of the breast is flowing. Okay, it goes from level 1 to level 2, from level 2 to level 3, and from level 3 it goes to supraclavicular lymph node. Right? All of you are understanding? पक्का? देखो दिल में कुछ नहीं रखना है. With me taking a class, दिल में कुछ नहीं रखना है. जो दिल में आ रहा है बाहर. Sure? Yes, sir. Okay. Now, whenever we are going to examine, please understand all these points will help you in answering a clinical question. What I see from various students that you have no difficulty. I know this. You don't feel you don't have difficulty when you are attempting a straightforward question. But whenever a clinical question is presented to you, you find it difficult to answer. You start, assuming, and you start taking guesses. You don't apply. You're not able to apply actually what you know in your theoretical understanding. This is what I gathered from the feedback from many students that sir, हम जब clinical question करते हैं तो clinical question में हमारे को गड़बड़ हो जाती है. अदरवाइज हम सिंपल स्ट्रेट फॉरवर्ड क्वेश्चन जो आते हैं जिनमें मोस्ट कॉमन लीस्ट कॉमन जो चैंटिंग करवाते हैं आजकल वो सब वाले क्वेश्चन हो जाते हैं. बट ये जो क्लिनिकल वाले क्वेश्चन होते हैं इनमें हम फंस जाते हैं. इनमें हमें क्लियर नहीं हो पाता कि क्या करना है. ये कॉमन प्रॉब्लम शायद तुम में नहीं होगी बट ज्यादातर स्टूडेंट्स में ये प्रॉब्लम दे आर फेसिंग. सो फॉर गेटिंग रिड ऑफ दिस प्रॉब्लम आई हैव मेजरली चेंज द वे आई used to. I will be giving you all the information which will be theoretical also, which will be clinical also, but then in a different way, so that you get the understanding of a theoretical point also, you get the understanding of a clinical point also. अब आती है बात, you are doing an examination. You know that you have to do examination of the breast in a dial-up plot method or a vertical line method. Commonly, we follow a dial-up plot method. Now, whenever, please appreciate all these points. Whenever a patient is coming to me, on the basis of examination, I have to make certain differential diagnosis. I have to decide that what problem this patient might have, right? So that impression I'm going to make on the basis of what I am getting on the clinical examination. Agreed, right? So on the basis of clinical examination, how will I know? There are primarily two kinds of problems in a breast. If we have to divide majorly the problems in breast, we can easily say there are going to be two kinds of problem in breast. One is a benign problem, another can be a malignant problem. So there can be a benign pathology, there can be a malignant pathology. So what impression the pathology should have on my clinical examination so that I can say that particular pathology is a malignant pathology. So you should know these points. If in any given question you on examination find a hard lump, when the lump is present in the breast and if that is hard in consistency, what does it suggest? Malignancy. So hardness is suggesting a malignancy. Second, anything other than this, what suggests a malignancy? Very good. When it is immobile or fixed to adjacent structure. So that means whenever in any given question you are told that on examination of this patient, the lump is fixed to particular thing, nearby structure, you should start thinking of that probably it is malignant. It is not confirmed that it is malignant, but your thought process should go towards malignancy. Anything else? Very good, very good. When it has a irregular margins or ill-defined margins also. So whenever the margins are ill-defined or irregular, again, I should think of a malignancy. Now, what is hard? Hard is this. Then what else? Louder. This is what you have to know. Pain is not a thing towards malignancy. It is towards a benign problem. Any other? Or guess? Or? Size. Size usually is not a criteria. Yes, you can say that sudden increase in size. Sudden increase in size if there, it is again a suggestion towards a any other location. Lymph node enlarged in axilla. Any other? Any other? If there is dimpling, puckering, or teethering mentioned. If in a given lump, dimpling, puckering, or teethering mentioned. What is this dimpling, puckering, or teethering? क्या दबाते हैं? देखो, what is dimpling, what is puckering, and what is teethering? देखो क्या है? Imagine this is a breast. This all is a breast, right? Which it is not. Just imagine, right? Where roof is the skin of the breast and floor is a pectoralis fascia. Skin is the roof of the breast and floor is a pectoralis fascia. Breast is on pectoralis fascia, you know that, right? And you know, breast is supported by a ligament of Cooper. Imagine this roof is supported by stands which are going from base to the roof, right? Now, you know, breast is a conical structure. It has a broader base and a narrow tail. So that means the ligament of Cooper at the base are going to be widely spaced, but at the roof they are going to be nearby, right? Imagine, right, like this. Now imagine there's a lump and here at the center of the breast, right? And this lump is invading ligament of Cooper. If this lump is invading ligament of Cooper, and ligament of Cooper we know is attached to the roof, that is skin. So what will happen if I move this lump from here to here? The skin will get pulled inward. So this pulling of the skin inward will give us a depression. This smooth depression which is we are getting here is called dimpling, a Shah Rukh Khan dimple, right? That kind of depression when you are getting, it is called dimpling, right? Now imagine another scenario. In another scenario, instead of lumping here, the lump is close to the roof, like a fan, like a ceiling fan, right? And again, the lump is invading ligament of Cooper, and at close to the roof, you know, the ligament of Coopers are nearby. Close to the roof, the ligament of Coopers are nearby, and these ligament of Coopers, imagine, are going through the lump like this, right? And that lump has invaded this ligament of Cooper. Now, if I try to move this lump from here to here, so instead of having a smooth depression which I had previously, every strand will get pulled separately. So when every strand is getting pulled separately, there will be multiple pits there in the skin. These multiple depressions which are getting on the skin instead of a smooth one depression, this is called puckering or teethering. So इसका मतलब क्या हुआ? Puckering and teethering or dimpling is happening because of ligament of Cooper, ligament of Cooper involvement. This dimpling, puckering or teething is happening because of a ligament of Cooper involvement. So if in any given question you are told that there is a lump and that lump is causing dimpling, puckering or teething, what will you start suspecting? It's a ligament of Cooper involvement, but what will you suspect in this lump? Malignancy, right? Now, if in any given patient there is a asymmetrical retraction of nipple is there, asymmetrical recent onset retraction of the nipple is there, then also you should start suspecting a malignancy. Now, what is this retraction? Let's understand this. See, this is nipple. Imagine this is a nipple. And in this nipple, there are like 15 to 20 lactiferous ducts running like this. You all know that nipple has multiple openings like this. It has multiple openings there. And what are these openings? These are nothing but openings of lactiferous duct. हम सब जानते हैं कि निप्पल पे lactiferous duct होती है. That is how the milk comes out. So there are lactiferous ducts present at nipple and there are 15 to 20. The number may vary. Usually there are 15 to 20 lactiferous ducts present at nipple, right? So if by any chance, please understand this, if by any chance one particular lactiferous duct gets shortened, contracted, if one particular lactiferous duct gets contracted, the nipple will get pulled inward. Nipple will get pulled inward, and this pulling of the nipple inward is called retraction. So, what does it mean? How the retraction is happening? What is causing the retraction? The problem in the lactiferous duct. So, retraction, what we understood from here, that dimpling, puckering, and teething happened because of a ligament of Cooper involvement. However, retraction of the nipple has happened because of involvement of lactiferous ducts. Got it? Now, you all know that malignancies have a uncontrolled growth. Malignancies have a uncontrolled growth. So, if there is a malignancy which is uncontrolledly proliferating, the fibrosis of the duct can happen irregularly. So when the fibrosis of a duct is happening irregularly, the nipple will get pulled inward irregularly, and that irregular pull will lead to a asymmetrical retraction of the nipple. So whenever in any given question you are told that there is an asymmetrical recent retraction of the nipple, it suggests malignancy. It is a suggestion. Please understand, it is not a confirmation. Don't take it as a confirmation. ये suggestion है. इससे हम आगे बढ़ेंगे. इस suggestion से हम कैसे आगे बढ़ेंगे? We will come to know, right? Then, if the patient has a discharge from nipple, if the patient has a discharge from nipple, and if it is a blood-stained discharge, the chances of malignancy becomes very, very high. Chances of malignancy becomes very, very high. So whenever any of these are there, you should start suspecting what? Malignancy. Got it? Now, so this is how we make an impression of a benign condition or a malignant condition on the basis of clinical examination. So this is our understanding of the anatomy and its clinical application also, right? Any question? सबको समझ आ रहा है? पक्का? कोई दिक्कत तो नहीं है? Right? देखो, please understand एक बात. हम सब theoretical बातें इसमें cover करेंगे. Don't worry about it. But हम इसको clinical format में cover करेंगे, right? जिससे तुम्हारे को clinical understanding भी आए और theoretical part तो cover साथ में होता ही जाए, right? So these are the things we have to take into consideration in anatomy correlating with the clinical, right? Now, first of all, then comes the investigations. Now, can you tell me what are the various investigations we have per se for breast evaluation? The investigations are primary. Let me first give you the broader classification and then you'll help me. The investigations are broadly divided into non-invasive investigation and invasive investigation. The investigations are broadly divided into non-invasive and invasive. Okay. Now, can you tell me any non-invasive investigation? Very good. One is mammogram. Very good. Mammogram. Any other? Ultrasound. Very good. Any other? Common पहले बात करते हैं, फिर हम MRI. Very good. Any other? PET scan. Very good. CT scan also we have started doing. So primarily these are the non-invasive investigations we have. In invasive, we have FNAC and we have biopsy. Now पहले इसको समझ लेते हैं. Let us first understand this. What is FNAC? Fine needle aspiration cytology. यार FNAC है तो FNAC बना दिया था. Fine needle aspiration cytology. Now give me answer to one question first, which is very easy question for you. I know that. Out of FNAC and biopsy, which is better? Why? In FNAC, we examine cells. In biopsy, we examine tissue, and tissue already has a cell. So it means obviously the tissue will give us more information. So obviously, out of FNAC and biopsy is better. Very good. Now, this understanding is a key here, and this is where most of the students struggle. Please, with me taking your class, you should not have that confusion at all. Now, in biopsy, we have three types of biopsies. True cut biopsy, which is also called core needle biopsy. We have incisional biopsy, and we have excisional biopsy. Okay. Now, first of all, I should be asking you this question only when I make sure that you know this. You know what we do in core needle biopsy? If you know, then we can proceed. Okay, so let's understand. Without understanding it, we will not be able to decide in a given scenario. True cut biopsy क्या होता है? What is this true cut biopsy? There is a needle. Please understand this. There is a needle which has a big core. There is a needle like this which has a big core, right? Inside this needle, there is a sharp knife-like thing. Inside this needle, there is a sharp knife-like thing. So what happens is, when I press this needle from outside, this sharp knife-like thing comes out. And when I pull this from outside, this sharp knife-like thing goes into the hollow component of the needle. It goes into the hollow component of the needle. Now what I'm going to do is, imagine there's a lump. Imagine there's a lump and there's a skin overlying the lump. Just imagine. What I'm going to do now, I will give a local anesthesia on the skin and I'll give a very small incision on the skin of the breast. I'll give very small incision like this on the skin of the breast, right? Okay, now what I'm going to do, I will insert this needle with a sharp knife-like thing pointing out like this. With a sharp knife-like thing pointing out like this, right? Now, once I've entered the lump, what I'm going to do, I'll pull this sharp thing. So when I pull this sharp thing, you can appreciate it will be something like this now. Yes or no? Yes or no, everyone? Now, what I have done is I have pulled the sharp knife like thing into the hollow component of the needle. Now, what I am going to do, I'll use my right hand, hold the outer part of the needle with my right hand, and I will push this outer part of the needle with force into the lump. When I push this outer part of the needle inside the lump, you can appreciate that the tissue from the lump will get chipped off. Yes or no? Tissue from the lump like this will get chipped off. Yes or no? Now what I'm going to do, I'll take this needle out. I'll take this needle out and I press the sharp knife thing from outside again. So when I press this again, what will happen? The tissue will be on the slide. Agreed? Agreed? So this is what is a true cut or a core needle biopsy. Everybody understood? Yes. Now, what I am going to do in a incisional biopsy, as the name suggests, there is a lump, there is a skin overlying the lump. So what I am going to do, I will give an incision on the skin, right? I will separate the tissues. I will separate the tissues, and then after separating the tissues, I will take out the chunk of the tissue from the lump, a part of the chunk of the tissue from the lump, and after that, I'll suture this skin. After that, I'll suture this skin, right? Now, this is incisional biopsy. In excisional biopsy, what I'm going to do, as a name suggests, I will give incision on the skin and I will take this lump out also. So I'll take this lump out from the breast and suture it back, right? So in a excisional biopsy, I have removed the lump. In a incisional biopsy, I have taken out tissue from the lump, a chunk of tissue from the lump, and in true cut biopsy also, I have taken a tissue from the lump. Agreed, all of you? Is the speed fine? All of you? Right? Okay. Now, you already have told me out of FNAC and biopsy. Biopsy is better. So now is the time to ask you, out of true cut, incisional and excisional biopsy, which is the best? सोच के बोलो, best कौन सी? Obviously, अनुमान जी को कुछ समझ नहीं आ रहा था, तो we got right. So excisional biopsy is the best because you have taken out whole of the lump and now you have a more information to gather, right? खत्म कर रहे थे. So best is excisional. But अगर मैं language question भी change कर दूं, now if I change the language of the question and ask you, out of these 3 biopsies, which one you will prefer doing? You will prefer doing core needle or true cut because cosmetically it is better, lesser insult to the breast tissue, and yet getting a diagnosis. So that means preferred biopsy is true cut and best or gold standard is excisional. Best or gold standard is excisional. ठीक बात है? We don't do incisional biopsy anymore. We don't do excisional biopsy anymore. Incisional. We don't do incisional biopsy anymore. Right? So या तो हम true cut करते हैं या excisional. अब listen to this information very very carefully and engrave it here. ये यहाँ पे घुसा लेना है. Excisional biopsy is the best. I just told you, excisional biopsy is the best, but we very rarely do excisional biopsy. We very rarely do excisional biopsy, right? And if we have to do excisional biopsy, listen to this first and then write, because समझ के फिर लिखना. Very rarely we do excisional biopsy, I just told you. And if at all we have to do excisional biopsy, we will only do after doing a true cut biopsy. I will never do excisional biopsy without doing a true cut biopsy as a rule. ये engrave कर लो यहाँ पे. तो किसी भी क्वेश्चन में ऐसा हो ही नहीं सकता कि आपका आंसर अगर पूछा गया है व्हाट इज अ नेक्स्ट, उस नेक्स्ट में ट्रू कट पहले अगर नहीं हो रखा और आप डायरेक्टली एक्सीजनल पे चले जाए. यू कैन नेवर गो टू एक्सीजनल बायोप्सी विदाउट गोइंग थ्रू. एक सिंपल सा बेसिक फंडा है. दिस इज अ सिंपल बेसिक रूल. अंडरस्टूड? ओके. तो अब हमें ये पता लग गया कि हमारे पास इन्वेजिव इन्वेस्टिगेशन में, प्लीज करेक्ट मी इफ आई एम रॉन्ग, कैन आई से दैट इन इन्वेजिव इन्वेस्टिगेशन, in true sense, I have two invasive investigations. In true sense, I have two invasive investigations only. One, FNEC and true cut biopsy, because excisional biopsy I am doing very agreed, all of you. तो ये हमने एक invasive investigation में एक basic understanding we got. Okay. Now coming on to the non-invasive investigation. क्या होगा? हाँ,
अगर वहीं पर डायग्नोज होती है तो वहीं पर
किसी भी बायोप्सी में your doubt is absolutely valid. हाँ, very good. Your thought process is very good. I'm really appreciating it. But the point is, when you take a biopsy, when you send a tissue, it takes minimum of 7 to 10 days to get a detailed evaluation of that pathology. So in the operating room, if you are getting a biopsy, the information which we get is not going to be as good as we get it in a lab. So that is why we tend to do this way. Okay. Okay. Now coming on to non-invasive investigation. हम इनकी theoretical बातें बाद में करें. हम अभी क्लिनिकल अंडरस्टैंडिंग को समझने की कोशिश कर रहे हैं. ओके. व्हाट इज मैमोग्राम? मैमोग्राम इज नथिंग बट अ एक्सरे ऑफ द ब्रेस्ट. मैमोग्राम इज नथिंग बट अ एक्सरे ऑफ द ब्रेस्ट. ओके. अब एक बेसिक सी बात हमें याद रखनी है, हमेशा वो एप्लीकेबल है एज अ रूल, वो कभी रूल ब्रेक नहीं होता. राइट? जस्ट रिमेंबर दैट whenever you are planning to do a non-invasive investigation. When are we going to plan a non-invasive investigation? I'll let you know. When are we going to plan a non-invasive investigation? We will come to know. But before that, we need to understand that whenever I have decided that I should be doing a non-invasive investigation in this particular profile of a patient, I will always first do mammogram. I will always first do mammogram. As a rule, remember. जब भी मुझे लगा कि मुझे नॉन इन्वेजिव इन्वेस्टिगेशन इस पेशेंट की प्रोफाइल के अकॉर्डिंग करनी है, और वो क्या प्रोफाइल होगी और कब करनी है वो भी हम समझेंगे, तो मैं हमेशा मैमोग्राम सबसे पहले करूंगा. एज अ रूल, राइट? except in those places where mammogram has a limitation. Except in those places where mammogram has a limitation. Mammogram, we will be talking about the theoretical points about it. Mammogram is nothing but an X-ray of the breast, right? So it's a radiation. So the limitation here are 1. Pregnancy. You can't give a radiation to a pregnant female. Second, lactating female. Right? And third, young female. So किसी भी given situation में, what I have just told you, in any given situation, I will always prefer mammogram except for these three situations. But then in this three situations, one situation is very dangerous. and that is a young female. Because आपको ये define करना होगा what is a young female, because every female thinks that she is young. तलवारें निकल आएंगी यहाँ तो. So what is the definition of a young female? Puberty के बाद तो ओल्ड कब हो रही है? मैं puberty के बाद तो यंग हो गई, तो अब तो यंग ही रहेंगे हमेशा. When you should think you should be young? This is not a valid question actually. The answer to this is as long as you want.
Till pregnancy.
The definition of a young here, according to the guideline, you can think yourself young till whatever age, right? But the definition of young as per the latest guideline is less than. Please, this is the latest. Pehle it was 40, then it changed to 35. Now it is 30. You can take yourself young for till whatever age you want, but as per the guidelines, it is less than 30. So you can also make out that how far you are being till the time you will be called young. So बहुत ज़्यादा दिन नहीं है शायद, महीने नहीं, साल नहीं है शायद. कोई भी pregnancy मतलब pregnancy, right? Now, ठीक है? So what we have understood from here that in any given situation we will prefer mammogram except for these scenarios. Understood? Okay. Now, imagine a female comes to you with a complaint of a breast lump. Imagine a female has come to you with a complaint of a breast lump. What will be your next line of investigation? So there is no confusion that we should always do clinical examination first. We should always do a clinical examination first. And in clinical examination, दो बातें होंगी. या तो lump होगा या नहीं होगा, right? There may be lump, there may not be lump, right? Now, and if there is a lump, if there is a lump, then there can be feature of a benign thing in that. There can be feature of a malignant thing in that. We know that. We know that now. We know that now. Now, imagine the lump is not there. What will be the next investigation? Who said use it?
Depends on the age of the patient.
अभी मैंने क्या बोला था कि अगर आपके दिमाग में नॉन इन्वेसिव इन्वेस्टिगेशन आ गई एक बार तो क्या आनी चाहिए? सिर्फ इन 3 सिचुएशंस को छोड़ के. It depends on the status of the patient. तो अगर मैंने स्टेटस नहीं बताया, मान ले कि यंग है, मान लो कि यंग है, मान लो कि प्रेग्नेंट है, मान लो कि लैक्टेटिंग है, नहीं ना? तो जब मैंने नहीं बताया तो नहीं है. अगर हाँ पता चल जाएगा. तो अगर एग्जामिनर ने नहीं बताया तो एग्जामिनर से क्या काउंटर क्वेश्चन करोगे? क्लिनिकल एग्जामिनेशन में पता तो लग जाएगा, बताओ क्या एज है हमें, क्या लैक्टेटिंग है या नहीं है, प्रेग्नेंट है नहीं है, लड़ तो सकते नहीं है. अब एग्जामिनर ने बताया नहीं तो क्या करे? जब तक नहीं बताया तब तक नहीं है, जब तक नहीं बताया तब तक नहीं है. अब वो हाइड एंड सीक तो खेल ही रहा है कि नहीं मैं तो नहीं बताऊंगा, तू करके एक आंसर. नहीं बताया तो नहीं है ना, अगर है तो है, नहीं है तो नहीं है. अगर होता तो बता देता, नहीं बताया तो मतलब नहीं है ना. ठीक है, तो तो वो कोई छुपा थोड़ी रहा है आपसे, राइट? तो लंप नहीं है, लंप नहीं है। आप क्या करें? मैमोग्राम, यू विल डू अ मैमोग्राम। ठीक है, बहुत इंपॉर्टेंट डिस्कशन कर रहे हैं हम इस समय। ओके, मान लो आपने मैमोग्राम किया। अब मैमोग्राम में दो बातें होंगी, या तो अब लंप मिल जाएगा या अभी भी नहीं मिलेगा। हो सकता है अभी भी ना मिले, हो सकता है कि नहीं हो सकता। तो अगर लंप नहीं मिला मैमोग्राम पे, क्लिनिकल एग्जामिनेशन पे भी नहीं था, तो अब क्या करें? क्यों आ जाते हो, मूड आ जाते हो? नहीं मिला तो आप सीटी एमआरआई करेंगे, क्योंकि हम क्राइम मास्टर गोगो हैं कि हम आए तो कुछ निकाल के जाएंगे। अगर क्लिनिकल एग्जामिनेशन में कुछ नहीं है, मैमोग्राम में भी कुछ नहीं आया, तो भगवान के लिए छोड़ दो। देयर इज समथिंग कॉल्ड रीअश्योरेंस and tell her that don't worry, you have no problem, come to me after 1 year. उससे पहले मत दिख जाना, right? Okay, so you will reassure this female. ठीक है? अच्छा, अब आपने लंप क्लिनिकल एग्जामिनेशन पे फील कर लिया, अब क्या करें? बायोप्सी कर, क्योंकि लंप तो मिल गया है, तो अब क्यों बेकार में दिमाग लगाना, है ना? ओके, अच्छा, जब लंप was not there on clinical examination, can anybody tell me why did you do mammogram?
The most common melanoma. Under deep tissue.
Why did you do mammogram when the lump was not clinically palpable? Maybe the lump was there, but you could not appreciate, because lumps becomes palpable. This is a rule. Any lump becomes palpable when it is more than 1 centimeter. So if it is less than 1 centimeter, you may not be able to pick it, or it is also possible that you fail to appreciate a lump. That is why you did a, इसीलिए किया था। तो इस सिनेरियो में जहां पे लंप मिल गया, तो आपने ऐसा क्यों सोचा कि ये अकेला ही लंप है इस पेशेंट में? नहीं, मोस्ट कॉमन तो होता है, बट ये किसने बोला कि एक ही होता है? और भी हो तो वो कौन पता लगाएगा? अगर आप इसी लंप के बारे में सोचते रहोगे और पेशेंट को और भी लंप हो, मान लो कि यहाँ पे भी लंप है जो आपके क्लिनिकल एग्जामिनेशन में नहीं फील हुआ, या फिर 1 सेंटीमीटर से कम था, या फिर यहाँ पे है, और अगर आप इसी लंप पे फोकस करोगे, तो अगर और लंप है तो आप पेशेंट का ट्रीटमेंट तो कंप्लीट नहीं कर पाओगे ना। तो इसका मतलब है आपको ये पता लगाना है कि एक ही लंप है या और भी है। There is something called multifocal disease. There is something called multicentric disease. What is multifocal? When multiple primaries are there in one quadrant. What is multifocal? Multifocal is when there are multiple primaries in one quadrant. Multicentric is multiple primaries in multiple quadrants. So how will we know that the problem is multifocal और the problem is multicentric? कैसे पता लगेगा? तो इसका मतलब है next investigation, correct me if I'm wrong, can I say that next investigation, be a lump palpable, be not palpable, is always going to be non-invasive? And what that non-invasive is? And if there are 3 limitations, then what will you do? If those 3 limitations are not there, we will be doing a mammogram. If any of the three are there, we will do. Understood? Now, after this mammogram, so that means be the lump palpable, be the lump not palpable. We have done mammogram, right? After this, we will do true cut biopsy. After this mammogram, we will do a true cut biopsy. So what we have done, let me summarize it. We have done clinical examination first, agreed. Then we always do radiological examination, either by or ultrasound. Agreed? After that, we did a tissue sampling in the form of true cut biopsy. These three things together, when done, this is called triple. These three things together, when done, is called triple assessment. These three things together, when done, are called triple assessment. Right? What is triple assessment? You know now. Okay. Now, ये बहुत इंपॉर्टेंट बात मैं बोलने वाला हूँ, इसको अच्छे से समझ लेना क्योंकि यही क्लिनिकल क्वेश्चंस का बैकबोन है. हमने सबसे पहले क्लिनिकल एग्जामिनेशन किया, उसके बाद हमने रेडियोलॉजिकल एग्जामिनेशन किया एंड फाइनली हमने टिश्यू सैंपलिंग की. तो अल्टीमेटली मुझे पहुंचना था यहाँ. Ultimately, once the patient has a lump, once the patient comes to me with a lump, I have to reach to a tissue sampling. But I will reach through the path of clinical examination, through the path of radiology, and then the true cut biopsy. So please understand this. This true cut biopsy here is called most appropriate step in a breast lump patient because it is a penultimate thing which I have to reach to. So the most appropriate step, which in other words is also called investigation of choice, is true cut biopsy. And if I have to ask you what is a gold standard, excisional biopsy. Understood, everyone? Okay, now let me ask you a question and let's see who answered it right. जल्दबाजी कोई नहीं है. क्लिनिकल क्वेश्चंस को हमने नैक डेवलप करना है कि कैसे आंसर होते हैं. ओके, क्लिनिकल क्वेश्चन एक बहुत ही अलग बॉल गेम है, राइट? और उसके लिए एक बेयर मिनिमम अंडरस्टैंडिंग ऑफ कंसेप्ट होनी होती है, नहीं तो आपसे नहीं सॉल्व होगी. ओके, लेट मी आस्क. A female comes to you with a hard lump in her breast. Which of the following is the most appropriate next step? Which of the following? Let me finish up the choices. Which of the following is the most appropriate next step? The choices are clinical examination, ultrasound, mammogram, true cut biopsy, excisional biopsy. Two. आंसर क्या है? आंसर बोलो। गूगल बैक। अच्छा। What are the features suggestive of malignancy? We know. Heart lump, it is suggestive of malignancy. Now we know this. Soft is like this. This is a definition of soft. This is a definition of firm. And this is a definition of a hard. Okay. Who knows it? We.
Not the patient.
Not the patient.
Not the patient. Not the patient. Patient won't come to you saying that I have a hard lump, I have a soft lump, I have a firm lump. So when it is said it is hard lump, what does it mean? Who said that? That means the clinical examination is already. अब question क्या है? Next step. Question क्या है? Most appropriate next step. तो clinical examination तो हो गया. तो क्या करें? तो टूकट बात से क्यों बोल रहे थे?
ये तो प्रॉपर्ली मेंशन होना चाहिए ना, तो आप पेशेंट का प्लेस करना हार्ड हो गया।
ये तो प्रॉपर्ली मेंशन होना चाहिए, बट एग्जामिनर तुम्हारा टेस्ट लेना चाहता है या फिर तुम्हारे साथ खेलना चाहता है? नहीं, अगर हार्ड लम्प बोलते हैं ना खेल ले रहा है, वो आपके अंडरस्टैंडिंग देखता है whether you know that who determines the lump is hard, soft and firm. It is you who will determine that it's a hard. अगर मैं यहाँ पे लंप रख दूं, तब आंसर क्लिनिकल एग्जामिनेशन है। अगर मैं इसको सॉफ्ट, फर्म या हार्ड डिफाइन कर दूंगा, तो इट विल बी अ मैमोग्राम। क्योंकि पेशेंट को नहीं पता कि इसको सॉफ्ट बोलते हैं, इसको फर्म बोलते हैं, इसको हार्ड बोलते हैं। हमें पता है, और ये हमने अभी बताया है दूसरे को। अभी तक हमें भी नहीं पता था, बाय द वे। ठीक है ना? तो लीव अलोन अ पेशेंट। ठीक है? सो हम आपने ओके, सबको समझ आ रहा है? अनदर क्वेश्चन और लो। A 45-year-old female comes to you with a hard lump in a breast. तो पहले वाले का आंसर क्या हुआ फाइनली? कंफ्यूजन नहीं है ना किसी को? 45-year-old female comes to you with a hard lump in a breast. Which of the following is the most appropriate step? देखो, अगर इतना सब डिस्कस करने के बाद भी अपनी गट फीलिंग से आंसर करना है, तो फिर तो क्लास में बैठो नहीं। हमने डिस्कस किया आंसर इज क्योंकि मोस्ट एप्रोप्रिएट नेक्स्ट स्टेप है मैमोग्राम। मोस्ट एप्रोप्रिएट स्टेप है ब्रूकर्ड बायोप्सी। हमें अल्टीमेटली पहुंचना है ब्रूकर्ड बायोप्सी, पर हम कभी नहीं पहुंचेंगे बिना मैमोग्राम के। समझ आई बात सबको? ओके, आगे और देख लेते हैं। एक और क्वेश्चन। 45-year-old female comes to you in different female, सेम नहीं आ रही बात है, तो जो यही एक ही बात आ जाती है। ओके, 45-year-old female comes to you with a hard lump in a breast. Which of the following investigation is most helpful in diagnosis? Answer. 1, 2, 3, 4, 5. 45 with an art of the breast. Which of the following is most helpful in diagnosis? पक्का? पक्का? तो समझ आ गया? यहाँ पे एग्जामिनर को फर्क ही नहीं पड़ रहा कि तुम क्या अप्रोच रखनी है, वो कह रहा है कि मुझे अप्रोच नहीं पूछनी, मुझे ये बताओ कि बेस्ट क्या है, और बेस्ट है, और हमें पता है कि बेस्ट भले एक्सीजनल है पर हम करेंगे नहीं, हम और करना भी पड़ेगा, करेंगे बट ट्रू कट से बात। समझ आई बात? पक्का? ये खेल है सारा क्लिनिकल क्वेश्चन, यही खेल है। A 45-year-old female comes to you with a hard lump in her breast. Which of the following is most helpful in diagnosis? तुमने खुद ही बोला था कि बेस्ट है पूरा लंप निकाल दो, तो यही पूछा, मोस्ट हेल्पफुल पूछा। हाँ, पिछले पे क्या था? बिल्कुल तो नहीं लिखा है, तो इसलिए तो आंसर एक्सीजनल है। क्वेश्चन पूछ रहा है आपसे, क्वेश्चन आपसे पूछ ही नहीं रहा है कि कब करनी है, क्वेश्चन आपसे कह रहा है कि सबसे हेल्पफुल कौन सी है सब में। मोस्ट हेल्पफुल पूछ रहा है वो, इन सब में सबसे अच्छा कौन सा है कोई पूछ रहा है, वो ये पूछ ही नहीं रहा कब करनी, वो कह रहे हैं इन सब में बेस्ट क्या है बताओ मुझे। एक्सीजन है, सबसे बेस्ट है, रिसेक्ट कर दो, ब्रेस्ट को निकाल दो, तो दुश्मनी है। कौन? ठीक है, पक्का? चले आगे। So we have understood the clinical approach. अब हम समझते हैं important theoretical points. Now we will understand the important theoretical points. Okay? Mammogram. Mammogram is nothing but a low voltage high amperage X-ray. Mammogram is nothing but a low voltage high amperage X-ray, and the exposure in a single mammogram is 0.1 centigrade. The exposure in a single mammogram is 0.1 centigrade, right? This is the unit of radiation, okay? And chest X-ray has 1/4 of mammographic radiation exposure. Chest X-ray has 1/4 of chest X-ray has 1/4 of a mammographic radiation exposure. Centigrade. Right? So means 4 X-rays equal to 1 mammogram. 4 chest X-rays equal to 1 mammogram. Okay. Now, then mammogram is done in 2 views. Mediolateral oblique and craniocaudal view. Mammogram is done in 2 views, mediolateral oblique and a craniocaudal view. Mediolateral oblique and craniocaudal view. Out of these 2 views, this is the better view. Mediolateral oblique view is the better view. Then the findings suggestive of malignancy in mammogram we should know. The findings suggestive of malignancy on mammogram are speculation or ill-defined, microcalcification, speculation, and presence of a high density lump. If the lump is high in density, if it has microcalcification on mammogram, if it is speculated or ill-defined, these are the points in mammogram suggestive of malignancy. These are the points in a mammogram suggestive of a malignancy. Then comes another very important thing, that on the basis of mammogram, there is a scoring also. That is a radiological scoring, and that radiological scoring is called BIRARS. What is BIRARS? Breast imaging reporting and data system. Breast imaging reporting and data system. This BIRARS full form they have asked in your exam 1. Then they have also asked about this score. We need to know what are the impression we get it in BIRARS. We should know. Score 0 is given. Score 0 is given when it is inconclusive. When the mammogram is inconclusive, we get score of a 0. Score 1 is given when it is a negative mammogram. No finding. Score 2 is given when it is a benign finding on a mammogram. Score 2 is given when there is a benign finding on a mammogram. Score 3 is given when it is probably benign. When it is probably benign. Score 4 is given when there is a suspicion of malignancy. Score 4 is given when there is a suspicion of malignancy. Score 5 is given when it is highly suspicious of malignancy. Score 5 is given when it is highly suggestive of malignancy. Score 6 is given for a already proven malignancy. Score 6 is given for a already proven malignancy. Right? So this Bayrard score is important for us. They can ask you what is 1, what is 2, what is 3, what is 4, what is 5, and what is 6. Okay. Then comes, we should know few points about MRI also. MRI is the most sensitive imaging modality. MRI is the most sensitive imaging modality. MRI is the investigation of choice for finding breast lump in high risk patient. MRI is the investigation of choice for finding breast lump in a high risk patient. MRI is also investigation of choice for screening high risk individual. MRI is also investigation of choice for screening high risk individuals. MRI is also investigation of choice for patients with breast implant. MRI is also investigation of choice for breast implant and implant related complications. Breast implant and implant related complications, right? And it is also investigation of choice for differentiating scar from recurrence. It is also investigation of choice for differentiating scar from recurrence. So these are the theoretical points. We will apply them again. Okay. Then we have PET scan also. PET scan is the investigation of choice. PET scan is the investigation of choice for systemic or distant spread of carcinoma breast. PET scan is the investigation of choice for systemic spread or distant spread of carcinoma breast. Okay, and the most common site of distant metastasis, most common site of distant metastasis from carcinoma is very commonly asked question is bone, not lung. Most common site is bone, and in bone it is lumbar vertebra. And very important point here in this is the metastasis to bone is both. Metastasis to bone from carcinoma of breast is both osteoblastic as well as osteolytic. The metastasis from carcinoma of breast to bone is both osteoblastic as well as osteolytic. But very important, if you have to select one, more common is osteolytic. More common out of the two, if you have to select in a given question, is osteolytic. Right? Now, so again, these were the theoretical points. अब बहुत important, पेशेंट हमारा, हमने क्लिनिकल अप्रोच डिस्कस कर ली एक नॉर्मल फीमेल. We have discussed the clinical approach in a normal female. Now let us understand the clinical approach in a high risk patient. Now first of all, what is a definition of a high risk patient? The high risk patient is who has a family of carcinoma breast. If a female has a family history of carcinoma breast running in her family, if she comes to you with a breast lump, if a female having a family history of carcinoma breast comes to you with a complaint of breast lump, what are you going to do in that female? We should know. What will you do? What is your next line of investigation? So if a female is coming to you who has a family history of carcinoma breast with a complaint of breast lump, आप उसे घुसते बोलो बार बार MRI अंदर मत आना, MRI करा के आओ सीधा. क्लिनिकल एग्जामिनेशन. ठीक है, आपने क्लिनिकल एग्जामिनेशन किया, दो बातें होंगी, या तो लंप होगा या नहीं होगा. और अगर लंप नहीं है तो क्या करें? लंप नहीं है, सो क्या करें? मैमो non-invasive. Which non-invasive? So we will always do mammogram. मैमोग्राम. ठीक है, आपने मैमोग्राम किया, लंप मिल गया, क्या करें? सेलिब्रेट करें? लंप मिल गया, अब MRI क्यों करना है? हाँ, क्यों करना है मैमो? अब MRI क्यों करना है? तो सीधा ड्रू कट करना है ना, पता लग जाएगा. तो हमें मैमोग्राम करने की जरूरत नहीं है, तो MRI करने की जरूरत नहीं है, तो हमें प्रॉब्लम पता लग गई. अब मैमोग्राम में नहीं मिला, अब क्या करें? हमने नॉर्मल फीमेल में क्या किया था? We reassured her because she was a normal female. She is a high risk female. We can only reassure her when we are very sure, and that surety we will get in this scenario only after doing a और MRI पे भी नहीं मिला तो अब reassurance. ओके, और अगर मिल गया तो वेरी गुड. समझ आ गई बात सबको? सो दिस वाज, तुम बताओ तुम्हारा दिल क्या कहता है? नहीं ना, तो जो दिल को सुनोगे क्यों कराना है MRI? जब आपका काम सुई से हो जा रहा है तो तलवार निकालने की जरूरी है. ठीक है, पक्का सबको समझ आ रहा है? एवरीवन. अब ब्रेक के कंटिन्यू.
Continue.